Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak to Dr. Lisa Cooper, a Bloomberg Distinguished Professor and the Director of the Johns Hopkins Center for Health Equity. Our topic is the participation of racial and ethnic minorities in the clinical trials for COVID-19 vaccines, why it is so important, why it is so difficult, and what can be done. Let's listen. Dr. Cooper, it is so great to have you back on the podcast again. And I want to talk today about the clinical trials for the COVID vaccines. And one of the key questions that has come up is the diversity of the trials, particularly the racial and ethnic diversity of the participants. Why is this an important consideration for the vaccine trials?
So first of all, thanks for having me back, Josh. And I'm glad you asked to talk about this particular issue because, this is something that has come up for a long time, is that in a lot of the research we do, the studies have included white men, but have not included, people from diverse backgrounds. And even for a long time, a lot of women weren't included in clinical trials. And so the NIH has come up with a number of requirements, really, that we include people from different groups in society in our research, because when we develop treatments, we need to make sure that the treatments are safe and effective in all people, really. Otherwise, it makes it seem as if we're using treatments that have been developed with certain people in mind on people where it's never been tested. And so, it's important to have that. It's also important for people from those groups to feel that the science represents something that is relevant to them.
So it's partly a question of the biology of what works and partly a question of people feeling like these medications or vaccines have been tested in their own community.
Yeah, that's really true. For the most part, I don't know that the biology differs that much in people of different racial and ethnic groups. We do know that biology can be different for men and women. But I think what's really important for people to know is that, for example, there are certain conditions where people from underrepresented groups in medicine, such as, Blacks, Hispanics, might be affected more by a certain condition. And so why would we have studies that are about hypertension treatment or about diabetes or about cancer treatments that impact people from Black and Latino communities at higher rates, but not have clinical trials that actually include those people? So, it just makes sense, from a scientific standpoint and just from a societal standpoint of, being inclusive and being fair.
Got it. But it's not always so easy to have a fully diverse clinical trial. What are the challenges that come up?
The challenges are that we have a long-standing sort of history in medical research and, even in public health research of actually doing things that were not always in the best interests of people from these communities. And so because of those historical factors, and, some of the examples include, for example, the Tuskegee study where African-American men were followed for many years and not offered any treatment for syphilis even after the treatment became available. And so,
right. I mean, it sounds like you're speaking with some understatement when you say not always the best. I mean, in some cases, research was really damaging.
It was damaging. It was misleading. And so, for good reason, people from these communities have developed a mistrust of science. And then also because of disparities in the quality of healthcare, people are concerned that even in healthcare that they might not get the treatment that they need, or they might be experimented on in some way, So we've seen this sort of play out in a number of different settings, even when you think about organ donation and organ transplantation, we see that, people from communities of color are hesitant to be organ donors because they're afraid that should they get ill and get taken to a hospital, even if they weren't sick enough or if they could be helped, that they might be left to die because somebody might want to just take their organ. So there's a real skepticism around whether health professionals and researchers have the well-being of these communities as a priority.
So you're left with a difficult situation because on the one hand, in order to build trust in medications, vaccines, it's important to have diverse trials, but because of a lack of trust, it's hard to get those diverse trials to happen.
Absolutely. Absolutely. So a lot has been done, with building of partnerships between academics and communities to sort of increase the trust that communities have in science and in medicine. And I think those are really promising ways to overcome some of these issues and really like incorporating community member perspectives in the design of the studies and getting their opinions and also about the messaging around the study, and then also having them actually serve as some of the messengers about the importance of being involved in the research.
So it sounds like it's both that there needs to be a thoughtful outreach campaign, but also that the research has to be designed in a way that is essentially attractive for people to want to participate in the study.
You're right. I think that a lot of times research is designed with scientific questions in mind, but not necessarily with the concerns or the specific challenges that people might face in being engaged in the research. So, you have like a scientific protocol where, there's a reason for the way the study is designed, but it's not necessarily clear to people who aren't scientists about why it's being done in that way. And sometimes the scientists haven't been mindful of issues that might be particularly fearful for people. So they might not address those specific fears or concerns, or even, people being worried about, for example, having to miss time off work to participate, or worrying about getting sick and not having health insurance coverage, to cover whatever complication they might develop as a result of being in the study. So lots of different things that really need to be included in the strategies.
I remember Senator Barbara Mikulski talking about some of the efforts to get more women in clinical trials. And she said she interviewed some scientific leaders and said, how come you have no women in these trials? And they said, well, there's no women's bathroom where we set up the research.
Yeah,
as if that was a satisfactory explanation. I don't think that answer went over so well with Senator Mikulski.
No, a lot of times I think scientists are thinking about sort of the convenience and the way to get the study done quickly. And it may not be that it's not easier to go to places where there may not be research facilities that have experience in recruitment and in data collection. Maybe people from diverse communities aren't in those communities, and you really would have to go and set up an infrastructure somewhere else, or really work with somebody who's already based in those communities.
Right. You can't set up a outpost in a place that is totally homogenous and expect to get a diverse group of study participants.
Exactly. And expect people to, travel long distances and all that sort of thing.
Now, what about the question of whether treatments and vaccines that are proven will be available after the study? And I wonder, it may well be the case that participating is a really, great thing for people to do so that there's good data about their community. But I wonder whether if there are questions about whether their community will actually have access to the treatments at the end, whether that could inhibit people joining the studies.
Yeah, I think that there are probably a range of concerns. I've heard concerns ranging from the fact that people feel that they are actually being used as quote unquote guinea pigs because that, maybe these treatments, because nobody knows whether they're safe or not yet, that scientists are more willing to experiment, on people of color until they find a safe treatment. And then, so that could be one concern on one side of the equation. The other side might be that, so then we volunteer for this. And who's to say that if we were to go in for healthcare, that we would be offered this? Because our experience has been that when there are new treatments and therapies, we're the last to get access to it.
So I know you've done so much great work understanding trust in the healthcare system and in research. I'm going to start with one question, which is, what's the wrong way to try to solve this problem? What would be maybe tempting, but not a great approach?
Yeah, I think the wrong way to go about this is to have generic materials that are distributed by staff who maybe have no experience in the specific communities that you're trying to reach, but who may be very well trained in the clinical methods or maybe have worked with, like you said, homogenous populations in the past. Going out, doing the recruitment or making the phone calls, distributing the materials, or using people to give the message out who have actually not been consistent in their messaging and who have already sort of generated a lot of skepticism. So we know that there have been a lot of myths circulating, conspiracy theories. We have leaders who are being inconsistent about what they're telling people about the safety and the effectiveness of the different vaccines and treatments. The wrong thing to do would be to have those people be the people that you rely upon to get the message out.
Right. So what needs to happen?
I think, part of the challenge with this is that, we have this thing called Operation Warp Speed. And that's sort of just counterintuitive to, building trust. Like you don't build trust with people rapidly. It takes time to build trust. So that's the challenge is we're trying to do this quickly, but it's only going to go as quickly as we can generate trust. So it's like it needs to be at the speed of trust, right? Instead of warp speed. What it's going to take is really scientists coming together with people who are viewed as leaders, people who are trusted from these communities, whether it's organizations such as the churches or schools or fraternities and sororities, whether it's it could be media personalities, sports figures, people like that who are viewed with respect and trust in the community, working closely with them, having listening sessions with people who are from the communities about what their concerns are, what their questions are, and what they would like to see. And then going back and really developing materials, developing messaging, hiring people from those communities to work on the research teams, and then maybe even testing them out with small groups of people before spreading it to the larger trial.
I know this isn't a short-term fix, but do we need more researchers who understand these challenges and can form these partnerships? And if so, how do we go about finding and training them?
So yes, we do. I think, we have several. We do have a cadre of people who have developed skills and expertise in community engaged and community-based participatory research. We have people who have been scholars in health equity research and interventions research. So we should draw upon them. We have some centers like that here at Hopkins. We have several around the country. And that's what the NIH has done recently. Actually, they just launched a large initiative that is called the Community Engaged Alliance Against COVID-19. And it's basically funding 11 different centers across the country in states that are experiencing really high infection rates, and really using experts from those communities who are working in partnerships with their communities to come up with a strategy to enhance the enrollment of these communities in the trials.
Well, I hope that effort is successful. I hope people take your advice on how to do it well. And I really I know how unbelievably busy you have been, really working hard on COVID and the immense challenges it poses for health and equity in our country and beyond. So thanks for taking a little bit of time to talk to me today.
Thanks for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.